Welcome to today's EMN5. This is the second of two splinting basics lectures, and this one is going to be on specific splints for the upper and lower extremities. So again, just as a review, this is the equipment and layers that you need to collect. You need a stockinette to protect the skin, Weberil for cushioning and to prevent skin breakdown over bony prominences. You need the actual splint itself, which you can either use fiberglass casting or plaster casting, and then you wrap the whole thing in an ace wrap. Make sure you grab a bucket of water and scissors. So let's go through a couple examples of a lower extremity splint. This is the post mold, and then you can do plus or minus the stirrup. This is shown with a stirrup. This is to immobilize the distal tibia, ankle, or foot. This is the medial lateral. It's used more for a distal femur fracture, the knee, or a proximal tibia. We don't use it that commonly, but it's good if you need to transport a patient who has an injury and you just need something to stabilize them. You can increase the strength with an I-beam formation, so you can fold the splinting material longitudinally with a central fold, and that really increases the strength of it. Again, this is a temporary thing, probably more for transporting the patient than actually sending them home with it. Let's go through a couple upper extremity splints. So first off, we need to talk about functional position. And this is the position that you're putting the patient in when you're applying these splints. It helps prevent joint stiffness and immobilization. And you have basically two options. First is the safe position. So that's the soda can. You use this with thumb spica and also with short arm splints. Then you have the intrinsic plus, where the MP joint is much more flexed, like 90-degree position. It's also the hamburger position. This is you're going to use for the ulnar or radial gutter splints. So let's talk about thumb spica. Again, this is the soda can position or safety position. This is for immobilizing either the base of the thumb or a scaphoid. So all those foosh injuries that you get, you're putting on a thumb spica to immobilize the scaphoid. For the short arm splint, this is more for immobilizing the metacarpal bases of 2 through 5, or a Colles or Smith fracture, or some of the other carpal fractures that are non-scaphoid. This is a really common one, especially in pediatrics, that you're going to use, again, using for foosh injuries with a Colles fracture, for example. And this one, again, you're going to be in the soda can position or the safety position. Next is the ulnar gutter splint. This is the one with the hamburger position or intrinsic plus. This can also be used with metacarpal fractures, but most specifically what you're going to be using it for is a fifth metacarpal fracture or the boxer's fracture. And make sure that your MP joint is at a 90-degree angle. Then we have the sugar tongue. This is for immobilizing the forearm or the wrist. This isn't a fracture that we think is less stable and you really want to prevent supination and pronation. So it includes a short arm splint, but also goes all the way around the base of the elbow and back. And that again prevents supination and pronation of the radius and ulna. After doing this splint, you probably need to put the patient in a sling just to help immobilize the arm. And lastly, we have the coaptation splint. This isn't used as commonly. It's mostly for a humeral fracture. Sometimes orthopedics just recommend actually putting the patient in just a sling for a humeral fracture. But if you think that they need a little bit more immobilization, you could put them in this coaptation splint and then have a sling in addition. One thing that we need to think about for humeral midshaft fractures is that 15% of these have some other injury. Can you think of what it is? So what nerve is that goes down along the humeral midshaft? Good, so it's a radial nerve injury, and 15% of these fractures can have a radial nerve injury, so you need to make sure and document a good exam. What you're going to see is wrist drop. So if you have any wrist drop in the patient, you need to actually put 2 splints on. You need to put a short arm on, splinting them in extension on the wrist, and then either do a sling plus or minus a coaptation splint for the humeral fracture. So to review functional positions one last time, the safety position or soda can is used for thumb spica and short arm. And the intrinsic plus with that 90-degree MP joint flexion is for the ulnar gutter splint. Thanks again for joining us on EMN5, and here are the references.